on to the next speaker and next topic. We will talk about supercomputing. We will talk about personalized medicine. I'm very, very pleased to welcome Professor Alfonso Valencia. We can applaud him. So Professor Alfonso Valencia is ICREA research professor here in Spain. He's as well the director of the Life Science Department at the Barcelona Supercomputing Center, which is one of the most performant, but you will explain us, supercomputer in Europe at least, and perhaps in the world. And you will explain us your research, long research. You have, I won't cite all the responsibilities you have because it will be long, but you are very involved in the European research in bioinformatics since several decades, and you are as well a promoter of different breakthrough concepts like the digital twin you will talk about in a few moments since many years. So I'm very, very pleased to have you on stage today, and please, the floor is yours.
Well, thank you very much for having me here today. So let me first introduce the Barcelona Supercomputing Center. As you already can imagine, it's a supercomputing center because we have a supercomputer. We are hosting Mare Nostrum. That is one of the largest computers, and we are in the process of installing Mare Nostrum 5 at the end of this year. That will be sort of a much larger computer in the order of something between 20 and 100 times more powerful than the current Mare Nostrum. So this is one, it's a public facility. It's a very large supercomputer connected with the other large supercomputers in Europe, and it's it's used by scientists in Spain and in Europe, as elsewhere, to perform complex calculations in many different domains. Obviously, we are more interested in the cases in which these computers are used for life science. So my department, the life science department, is performing research in different areas of biology and biomedicine using this type of computational facility. So what I'm going to tell you is about personalized medicine seen from the point of view of data and computing. So this is a standard view of what we understand for personalized medicine from this computational point of view. We obviously need computational infrastructure. We need the computers, the databases, the data resources to be able to handle genomic information. As you obviously know, genomic is becoming pervasive. It's everywhere from all the kind of applications for many different purposes, and obviously for medical applications. Genomic is evolving very fast, technically speaking, competing with the evolution of computers, and we have to be able to incorporate these different areas of research in genomics into the medical practice. The complementary view is the phenotypic data. We cannot analyze the genomic information if we don't have the corresponding information about the patient's characteristics coming from the medical records, from the imaging, from the medical devices, from the watches and the other devices, the epidemiological data, the social data. So these two images, the genomic and the phenotypic, has to be complementary, and we have to be able to analyze the two of them simultaneously. Obviously, once that we are there, we need to produce data integration and be able to translate this combined analysis of genomic and phenotypic information into recommendations to doctors, patients, treatments. This, we have been talking about this for years, and has been evolving slowly in the academic side, but now has become big, has become in the implementation stage. These are three examples. This is the European health data space, trying to implement this idea of personalized medicine at a large scale in the medical domain. This is an example of one other European country, and this is Switzerland, the personalized medicine initiative, Nordic countries, France, Germany, and the one on the top left is the Spanish one, Impact, that started a year ago. So now the European countries, plus obviously many other countries, are moving to a real implementation of this idea of combining genomics and phenotypic information in medical practice. Just to give you an idea of the complexity of this scenario in Europe, We have on the left the European Open Science Cloud. This is the academic research, open data, open software, how to deal with the data in the academic environment, in research. On the other hand, we have the European Health Data Space, how to organize medical data for primary care, for primary use of the data, and for secondary use of the data, for research. And in the middle is the Health and Research Innovation Cloud, trying to combine these two worlds, the research world and the medical data world. And there are many different projects, the 1 million genomes, the cancer mission, in this environment. So we are in a crucial point in which the medical domain and the biological domain are really encountering one to the other, and they need each other. So a very interesting, positive moment. Why this is happening? Because biology, biomedicine, medicine is producing enormous quantity of data. It's not the first producer of data. Videos are producing more than biology, but it's becoming one of the faster growing data producers worldwide. So the need of hosting, analyzing this data is very much promoting this need of combining, being able to operate in this data world. So the first part is computational infrastructures, being able to deal with genomic data. I'm not going to dedicate more time to that. We have organized infrastructures. Elixir is the European infrastructure to handle biological, biomedical data. The Genome Phenome Archive is a database that is hosting human genomes of medical value and has a federated structure. So we can keep the genomes done in Spain, according to the Spanish legislation in Spain, and interoperate them with the genomes produced in France under the French legislation. So we can do these federated operations. And we can do this in theory and in practice. These are different hospitals in Barcelona combining the data. They are exploring, they are sitting and doing this in practice, asking questions across the different domains, asking, do you have this type of data? Do you have this type of data? Can I build a virtual cohort based on the data distributed in the different hospitals in Barcelona? And I show the picture because this is operational. This is already working. At the European scale, this is the 1 million genome, also based in this federated structure of EGA, in which we try to do this not in the local Barcelona, but at the European level, sharing the data of about 1 million genomes between different European countries, based on this federated technology. The difficulties, as you probably realize, we are doing a lot of progress on the genomic side. The difficulties are now on the medical side. How to get information out of the medical records, medical images, how to get this out of the silos, the hospitals and the research different organizations, and how to make this operational in the framework of the law and the limitations, the ethical and legal limitations. And the thing gets complicated. I'm not going to go through the different processes that are needed to get the information out of this collaboration with the Hospital Clinic in Barcelona. These are the different stages and operations to be able to get the data out of the hospital in a way that can be used. So it's not a trivial, there's a negative part of that. It's not a trivial process. There are many different steps on this process, and this is for COVID-19 data. The positive side is this can be done. We have covered all these developments, and we can really go from a question to the data and produce the data in a standard format that can be used for research. This is, again, without entering into details, in practice, can we ask a question about COVID and get the data to answer this question following the different formats? Yes, it's a process to do that. It's complex, requires intervention, but can be done. The second and very challenging and interesting question is, okay, this is fine if we are interrogating the medical records for the standard information, the codes that the doctors and the curators has already introduced, the ICD-9, the ICD-10 codes. But there is a lot of information that is just written in plain text. Can we retrieve the information from the plain text of the medical records with natural language processing technology to be able to recover this information? And I give you the example that I'm using these days is the following. For a COVID-19 case, the most important information is the point in which this person suddenly gets worse in the hospital, because this is the indication that something serious is happening and they have to move this to the intensive care unit. This is not coded with any code. It's simple writing in plain text, and there is 1,000 ways in which you can write this, getting bad soon, suddenly worsening, etc., etc. In the case of these medical records that are written in Spanish or in Catalan, so we can even have a combination of Spanish and Catalan. So this is real. This is a real example, being able to retrieve from medical data, again, collaboration with the hospital clinic in Barcelona, diseases, symptoms, drugs, and negations. Most of the information in the medical records is negation. This person doesn't have that. This is critical, and you cannot make a mistake. You cannot say this person has that or not have that. So being able to recognize negation is a critical factor. Being able to recognize time is a critical factor when this drug was administered. This time of to be able to follow the chain of events. So I will say a few words if I have time, more about how we use natural language processing to be able to retrieve information from the clinical records. And obviously, when you do all that, you also have to normalize. And this is the key of the problem. If we operate in a hospital and we are extracting information, that's fine, that's interesting. But we need to normalize the information in a way that we can combine the information from different hospitals and different sources, and we can really operate at the semantic level. We have to be sure that they mean the same thing when they say measuring temperature, how they are measuring temperature. Are these things equivalent or not? And this is going to be the most difficult part of all this endeavor. So imagine that we can do that. We can do genomics, find the data across different countries. We can extract information from the medical records. Now we have to combine the two things. Can we do that? I'll show you one example. There are hundreds of examples of doing that. My example is in a child cancer, in medulloblastoma. And this is a network that contains two very different and interesting information. The green one is information extracted from standard databases. So it's information about genes related with this disease. The blue part and the sort of orange or red part is information extracted from publications and from textbooks and from literature. So we can combine information from standard databases and from literature, information about genes and information about diseases and characteristics. And we can combine these using science technology, machine learning, not going to enter in the details, with all the other information in something we call multi-layers. The consequence is that we can analyze a disease and produce a much better definition of the subgroups and a better classification of the patients. And at the same time, we can provide explainability. We can explain why these 4 different classes of the disease are separated one from the other, what makes them different. So yes, we can use technology that is already there to combine genomic information, phenotypic information extracted from many different sources. Obviously, this is the critical point. How well are we going to do being able to get information of genomics, on phenotypic information, from databases, from the literature, from the medical records? And this happens just in the revolution, in the middle of the revolution of the artificial intelligence. This is from this year in the newspapers and in the scientific literature, machine learning, artificial intelligence solving one of the key problems in molecular biology, how to predict the structure of proteins. This is an area in which I have spent 30 years, and now some is practically solved. So we see how machine learning is solving problems that has been there, really hard scientific problems, in a year. So now this area is disappearing, essentially. So obviously this has direct implications for medicine. This is Marta and Maite. They are developing Aina and Maria. Aina and Maria are the more advanced model of the language for Spanish and Catalan. These are very large language models from natural language processing from these 2 languages, Spanish and Catalan. So this is possible now and was not possible a few years ago because there has been this revolution and the Now it's possible to use these deep neural networks to train them with a lot of text and being able to almost understand text, and our case is Spanish and Catalan. And this is what is behind everything. When you're told to your Alexa, Alexa is a model of language that is understanding what you are asking and answering according to that. And you have seen full text written by the natural language processing systems. Mostly in English. All this is developed in English. The question is developing this for other languages. This has a cost. We are training these models with very large data set in Spanish, for example, from the National Library of Spain, and training this using a lot of computational capacity. So we can do this because we have a very large computer to train the next model of the next generation. Now we are training a GPT-2. To train a GPT-3, we need to have the next Mare Nostrum 5. So this only can be done in a very few places. Why this is important? Because otherwise, it will not be possible to get this level of resolution analyzing medical text. So we need the language models as the basis to be able to interpret text in many areas, but for us, in this area of biology. So there is an incredible progress in the way we can obtain information now from the literature, from the medical records, thanks to the language models, and for us, obviously, to be able to do this in our languages. And then, obviously, there is a large effort in Europe, because at the end of the day, all the European languages are very small in comparison with English, and they need to develop similar efforts to the one we are doing for Spanish and Catalan. So obviously, this is only what can be done with data, with a lot of data, with machine learning, being able to get data from different sources, integrating, and using these type of technologies. The real challenge for the next years, beyond being able to do all that is already complicated enough, is to be able to provide mechanistic understanding of the diseases. And I leave this with you as the ultimate challenge of biology. One thing is to say, I can classify this patient, and that's great. I can do a better treatment because the classification is better, and the tumor board will know better what to do with that. That's great. That's very useful. That's what we are doing. But at the end, we need to understand the origin of the disease and the molecular basis, the process behind the disease. In my way of thinking, understanding will mean to be able to develop a model that will be able to reproduce reality. Only if we can model, we can really say that we understand. So this is the challenge, and we are taking the challenge full way. We have a full program to do that, being able to take the data, in this case genomic data, single cell data, an amazing technology, being able to model what is happening inside each one of the individual cells, what happened among all the combination of cells. You can imagine the interaction between cells in a tumor, and being able to reproduce what is happening in a tumor, in an organoid, in a biological system. So this is, if this is working, maybe no. Well, there are some nice videos that are not working, but you can imagine that there are some 3 very nice videos of a simulation at the molecular level. We can do simulations of a drug binding to a protein. We can do a simulation of an organ moving and reproducing the electrostatic behavior, or we can do simulations of a tumor growing and being attacked by the immune system. None of these simulations will be perfect, because we are still working on all these things. The question is, are they good enough to generate hypotheses that can be tested experimentally? Are we making models that will help us to understand, in this case, the tumor evolution, in the other case, a malfunction in an organ, or in the other case, a drug binding, to a level that is detailed enough to provide hypotheses that can be tested experimentally? And obviously, the challenge is to be able to put all this together in what we call the digital twin. This is a dream. We cannot do that. If Anna is coming to the clinic, we don't have now the ability to have a model of Anna that has been prepared previously. We can introduce this new data and prepare a treatment that is specific for Anna with all the information we have. This will be the digital twin of Anna. In the same way that we have digital twins for many other areas of engineering, the dream is to have a digital twin for biology, for ANA, for a medical process. We are not there. My question, and I leave it with a question with you, is, will this be possible in 100 years? 100 years, no, 100 years, anything can happen in 100 years. Will this be possible in 50 years? Well, probably not 50 years. If you look back in 50 years, many things have happened. Will this be possible in 10 years? Maybe no. The question is not if this is going to happen. The question is, what can we do to make this happen sooner, faster? Otherwise, we will miss this progress, for which we have many of the elements. I told you about progress in data, progress in computation, progress in artificial intelligence, and progress in simulation. So we have many of the elements to make this, if not the full ANA, at least pieces of ANA. Thank you very much.
Thank you very much, Alfonso. Please take a seat. We will take a few minutes for questions and comments. We already have, well, I see we already have a series of questions. Please, microphone. Where is the microphone?
Microphone is running.
Yeah. These gentlemen here and here. Well, we made a bet a few years ago on 10 years for this digital twin. We have to respect this bet.
Hello, hi Alfonso. My name is Jonathan Gomez. I belong to the Regional Ministry of Health and Social Policies of the government of Extremadura in Spain. We know each other because of other things. My question is very focused on the barriers you can find in order to take advantage of the medical records. So the barriers are more related to, data privacy, data ownership, for example, because in the end, the data belongs to the user, belongs to the patient. So, or it's more that not having enough resources in the healthcare system to map those data and so on. So what is your opinion about that? Thank you.
Yeah, no, very, very good question. And obviously, that's the problem behind all that. The three of them. So there are obviously technical and economical problems. Many of the health systems don't have the capacity that, the clinic, for example, that is a very advanced hospital in this case, to do that, to be able to extract the data from the system, because it requires an operation, it's expensive, and this is a huge investment. To move all the Spanish health system to a level in which they can do something like that is an investment that has to be done by the health system, and it's going to be expensive. In my view, less expensive than not doing that. But still, as you know, that's an economical problem. We have the opportunity to solve this now. And there's already quantifications of how much this will cost, and I think that there is enough evidence that this is better to do it as soon as possible. Then obviously there are legal barriers. The data will not leave a certain domain, because there are obviously a legal framework to do that. I think that there is enough technology to be able to overcome these barriers. And then there are the others that are, so these two are barriers that are justified. You need the investment, so we have to do the investment to have all the system working. There are these technical, legal barriers. We have overcome them. It's logical that they are there because they are there for good reasons. The others that are less logical are the ones that are done with idiosyncrasy of places, no? We can do it, but we don't want to do it because we don't trust it, or we don't dare to, or what are we going to gain, or these kind of questions. And these are the ones that we should really not have. And that thing is a question of education, and you are in a very good position to educate your community to do that, and I know that you are doing that. So I think that we have done a lot of progress. The aim of IMPACT, the Spanish National Genome Project, Medical Genome Project, is to demonstrate that this can be done in a given domain, that we can do this not for everyone, but in 7 places. And with a real example of this working, show the others, no, you should do it too, and you should do the investment to do that. So that's what we are trying to do.
Thank you very much, Alfonso. We had another question here.
Thank you very much for your great presentation. My name is Chris from NEMU Software Development Company. We're building actually real-time monitoring system for patients. And my question would be, I've recently discovered that the NASA has real-time system monitoring for their astronauts. How far, according to you, we are from implementing this technology to the hospitals today in Barcelona, for instance?
Yeah, no, it's not my specialty. Obviously, talking to people, you know that there are already a number of systems in place that are already being tested, approved, or in use. And we are back to the previous talk that was very interesting. There are more systems ready to be used than system that has been accredited to work in a system. And we have a huge problem of testing, and it's problem of testing devices and continuous monitoring, and problem of testing machine learning systems that are going together with these technologies. Our approach, and we are trying to convince governments to do that, is that we need validation of this technology if we want to be convincing. And validation means open accreditation in a public, trusted place, in which the machine learning will be a good example, in which we have training data, testing data, machines to test the systems, and we can really test a system that is offered to a hospital and say, okay, after testing in a sufficiently good way, the system, the accuracy is that, the level is that, and the problems are this one. Otherwise, at least in Spain, in other countries too, for the health systems, it's very difficult to buy anything because they don't know what they are buying. So my quest is for getting enough resources to have this sandbed that are really validating the technology, but at the same time, technically, it's possible. We have done this in many areas of bioinformatics. We can also do it in areas of medicine. Without that, it's going to be very difficult to do progress because or you buy things that you don't know what they are doing, or you don't buy them, and then you don't get any benefit.
Thank you very much. Do we have a last question? So, just to conclude, the Supercomputing Center in Barcelona is open to, is doing a lot of international collaboration. Which kind of partners you are interested in? Which kind of profiles? Industry, academics, but which kind of competencies and skills you're looking for?
Well, first of all, it's a public center, so we have a lot of collaboration with other research institutes everywhere, or networks of collaborators. We have a lot of collaborations with all kinds of companies. Obviously, IT companies, because it's very natural, but also with application companies in all kinds of areas, because we work from climate to engineering to biology, and these are research contracts. We don't do work for work for companies. We work with companies in research projects, and we have a large portfolio of companies working with us. And we also have created 8 spin-offs in the last 3 years. So we are also very much promoting the research that we do be translated to applications in many different areas of biology and natural science in general, engineering in many areas of engineering. So we are very open to all these type of collaborations, and we are always looking for talent, hiring people from biologists to philosophers to engineers to anything.
So the call is launched, so anybody interested can discuss with Alfonso, because it's a great organization and a great person to collaborate with. I can testify of that. I had the experience a few years ago. Thank you very much.
Thank you very much.
Thank you very much for being here.